Okay, so shit.
يا عبد كيفك سامعينك شايفين الفيديو راح هاي كده ظاهر.
كده ظاهر. الفيديو ما ظاهر معايا أنا.
لكن ظاهر لنا
أنت ظاهر؟
ظاهر لنا الفيديو حقك وظاهر لنا صوتك.
لكن العجيب أنا ما قادر هنا فيديو شات يفتح عشان نفتح هي الصورة اللينك. كده واضح؟ الو.
الصوت واضح والصورة واضحة. الصوت واضح والصورة واضحة.
طيب let us start this lecture on the series of infectious and tropical diseases. We meant that these lectures will act as a short notes or short ideas or updated ideas, in a matter of fact, to students and doctors and those specialists who would like to seek a course or to seek a specialization in tropical medicine. We have dealt with up to now 14 lectures. This is the 15th lecture, which I'm enjoying, and I hope you are enjoying it too. Okay, the last lecture I ended with a quiz. The quiz was a disease. What is it? Reported first cases in 1981 with 4 or 5 cases in San Francisco who had Pneumocystis carinii. And then later on in New York, a cluster of other patients has been noted having same opportunistic infections. Later in Uganda, a disease was described as a slim disease. These patients will get very severe diarrhea for over 6 months. They become so wasted and they succumb to opportunistic infections. So this is the trace of those patients in the USA went back to San Francisco. A party of homosexuals who were enjoying themselves every year, and they were feeling liberal about whatever they do about sex between themselves. So thereafter, in 2 years' time, it was discovered that this is a virus. This was a virus which causes immunity suppression. And so from there, we learned that HIV/AIDS is a viral disease, and it spreads so rapidly, especially in Africa, where there are no precautions, and people used to take the diagnosis of HIV/AIDS as a death penalty, as a death certificate. So it's that bad, but thereafter, no vaccine was received to, and the disease starts to be treated by a novel antiretroviral therapy, which changed the disease from a death certificate into a chronic disease which can be at bay. The viruses will be reduced so much the disease will not be overt, no morbidity, and patients will feel well as far as they are taking the antiretrovirus therapy. And this is becoming just like hypertension. As much as you take the drugs, as long as you take the drugs, then you are normotensive. I'm bringing this because the worm I'm going to talk about is very much related to the immune system of the body. It is the HIV/AIDS has taught us a lesson about how strong the wall of immunity in the human body. We are here and we live in different environmental situations because of our immunity defense system. Once it breaks, then problems occur, and we will succumb to infections which will not kill. And normally, normal people will succumb to opportunistic infections and even cancer, certain cancers like sarcoma, Kaposi sarcoma, which used to be not very prevalent before the HIV/AIDS. It became prevalent with a lot of patients with HIV having Kaposi sarcoma. So the break of immunity, you remember, also we don't want it to be overdoing it, because if the body overdoes it, like autoimmune, we get also diseases like rheumatoid arthritis, systemic lupus erythematosus. So some infections like tuberculosis are in latent state, and they remain latent as far as the immunity is reserved or preserved. But once the immunity is broken down, then the infection like tuberculosis will become so overt and becomes ill. So much that now in Africa, the clinics of HIV is HIV and tuberculosis. So these are now getting very close together because of lack of immunity. A similar worm is Strongyloides. Strongyloides Stercoralis is a worm which lives in human body, and it breaks and gets invading the body very rapidly, causing a lot of symptoms, a lot of disease, even fatal disease in patients who have broken immunity. And you remember, you break the immunity by viruses like HIV virus, or by drugs like immunosuppressive drugs for patients who are having transplanted organs, or patients who are receiving other drugs or have lymphomas or cytotoxic drugs. So it is that bad if you break the immunity by drugs, and Strongyloides is one of the infections which can prevail in the body. Okay, Strongyloides Stercoralis is a nematode, and we remember we have been talking about the heading is Geohelminths, or nematodes of intestinal, okay, that are related to the soil. So this is why we call it soil transmitted helminths. And there are other helminths or other worms which are not soil transmitted directly, but they are in an indirect way soil transmitted, so we don't include them under this heading, like, say, Tinus aeginata. It's an intestinal worm, but the infection comes from a raw beef, which is infected by the larvae of the Solia Tinus oleum. So we restrict ourselves to the definition of Geohelminths. These are direct. Infection from soil can occur by ingesting the eggs of these worms. When people defecate in the open, they need grass. These worms, these eggs need grass, moisture, humidity, and then they grow. The eggs can mature in the soil for some time, or they can hatch and give larvae, which the larvae in turn can penetrate the body. So it's feces, what we call fecal-oral infection. If you remember about feces and what it can contaminate, what it can bring about in diseases, you will get surprised. The whole tropical diseases, or a lot of it, may be related to fecal-oral. And this is why nowadays civilization is about how distant you are from your feces. If you are using a siphon, you know, they are so distant from your feces. But if you defecate, you empty your bowels in the open, the grasses, and then once you get up, you know, you just press it, so go walk over it, then you are not away from your feces. So it is important that we remember that much of the nematodes or infections of gastrointestinal tract is due to oral contamination by feces, either direct, hands by hands like children, or by eating vegetables or whatever, or just digging or the ground. So the patients become very near to their feces or other people's feces, and they get contaminated. As far as nematodes of Geohelminths, we have the eggs, like Ankylostoma, Ascaris. This is eggs, Trichuris, eggs. But then we have the larvae. Some of the worms will mature, their eggs mature in the feces, in the soil, and they hatch to give larvae, rhabditiform larvae, which penetrates the skin. And this is, we have seen it occurring in Ankylostoma duodenale. And the other worm is Strongyloides. Also, it hatches in the ground and then comes out as rhabditiform larvae, which is L1, not very mature, but once it gets into the body, circulates through the systemic circulation, like Ascaris. They go from one area to another. They go into the body, they go into the liver. From the liver, they go into the right heart, and then they go into the lungs, where they can cause some lung problems or respiratory problems. And then from there, they jump the epiglottis. Funny enough, they jump the epiglottis to get into the esophagus, which is and then into the intestine, where they can rest. You remember this? They do the funny things of maturing when they are circulating, but they don't settle in the intestine once they are in. No, they go in, penetrating the muscles and the mucosa, and get circulating the whole circulation. By then they are mature, and then they settle finally in the intestine. So this is the similar Ascaris, similar to others, but in Strongyloides there are some differences. Difference one is there are very little eggs that comes from the human, because these are adult worms, live in the small intestine, and they produce eggs, but the eggs are being hatched within the intestine. What happens? The larvae can go out, okay, through the anus into the soil, or they can reinvent. They do a U-turn from the anus into the perineal region, and then get again access to the body. And the same larva which immigrated by the intestine, by the anus, they get back in the perineal region, and they get circulating to develop another cycle of infection. Or the adult worm produces the eggs, hatch, the larvae will penetrate the mucosa. Instead of going down the anus, they go penetrate the mucosa and get the same circulation like its mother when it used to be a larva. So this is what we call auto-infection. And in a matter of fact, this is one of the characteristics of Strongyloides Stercoralis. Okay, so the infection can be there within the human body for years. It's been reported up to 30 years. This infection can circulate, and mostly it is asymptomatic. So they are kept quiet, just a latent tuberculosis. Once the immunity is broken, then everything, start multiplying, the larvae from external to internal, and so on. So the larvae will go from liver to lungs to brain, and causes a lot of illnesses. The duration from larvae by mouse to larvae by anus is round about a month and a half. So it takes time. So the what we call, there is two cycles, two sexual cycles, one internally in the body, like what I described, and one externally, which is in the soil. And once the soil is not favorable, then you find the one in the body is activated. So this worm maintains its life very well within the body. So it's the difficulty with strongyloides is diagnosis, because with caries, trichuris, we get eggs, and eggs are a passive organ, so we can collect them from the feces. But the larvae is a motile, rhabdidiform larvae is motile, so we cannot recover the larvae very often unless we use a lot of procedures like concentration, like collecting overnight, and so on. So it's not easy. This is why the overall number of patients who is affected with strongyloides is underestimated because of the lack of actual diagnosis. So the diagnosis can still be made, from stools or from an aspirate from the duodenum. You can put a tube or a capsule, you can collect the duodenal fluid and then look for the larvae, and then you can find it. Or, as we're going to say later, there is ELISA technique, and there is PCR technique, which is more accurate. So either the stools for larvae, aspirate from the duodenum for larvae, and PCR and ELISA technique for detection of strongyloides. So where can we find the strongyloides? It's in tropical and subtropical, but it is not limited to that. It can even be seen in temperate climates in the Western world, and particularly in the Caribbean and South America. And with HIV/AIDS now, its diagnosis is becoming more and more common. So, what are the symptomatology? First, like most of the worms, if you have a small number of them harbored in the body, then usually there is no symptoms, asymptomatic. And so it lives happily there, the immunity is curtailing the spread of the larvae, and that is okay. But once the infection gets out of control by suppression of the immunity, then you get a lot of symptoms. This is why we talk about the acute phase of the strongyloides, the chronic phase, and then the life-threatening disseminated form. Life-threatening disseminated form. The larvae, when it enters in the body, it causes purpuric itch and a small ulcer in the leg. It continues, funny enough, for 2 weeks, and this is the larvae gets in and then gets access to the systemic circulation and does the circle which you have been describing. So that is what is the infection is like. And it's often noted that the infection is mainly in children, mainly in malnourished, and mainly when there is an overcrowd of persons in prisons or hospitals. So this is the first stage, which is in the skin, and then it passes. And like most of the worms, this is more pronounced in patients who are not from the endemic area, because people in the endemic area has been sensitized to the antigen and they don't react very, very severely like people who are coming from outside. The chronic phase, is in immune competent patients. This is usually mild abdominal pain, vomiting, and distension, and sometimes weight loss. This is very much like, irritable bowel syndrome, like infection, bacterial infection, dysenteric infection. So this comes from time to time, but it's not disturbing. It's not very disturbing. The second presentation is rash, skin rash. There are two types of skin rash with strongyloides. The larvae goes in the skin and then rapidly disappears, leaving a line. And this line is not indurated because it doesn't contain the larva. It's not indurated. It's different from the other larval migrants, which occurs with some hookworms. So these streaks are called larva carens, Currens, larva carens. And this is streaks which disappears from place to place, and they are not indurated. So the larva has been moving in the skin, and it occurs in the perianal region, perineal region, or in the buttocks, and you can see it, it's very, very clearly, okay? It is representing the larval tract, the other itch is, when the larvae does the U-turn, getting from the anus around into the perineal skin, giving you the itch around the anus, simulating other worms like Enterobia spermicularis, which cause anal itch. And this is one of the anal itch. You remember we said there is an anal itch and there is a ground itch, and in schistosomiasis there is an avian or swimmer's itch of the bears will drop the schistosomes cercaria into the water, but they never develop into full schistosomiasis. So there is an itch around, and obviously the disease with very severe itching is onchocerciasis volvulus, you remember, river blindness. So there is an itch with a lot of worms, and this is one of them is the strongyloides. What is the cutaneous larva migrans? This is confusing with the larva carens of strongyloides. The cutaneous larva migrans are usually migrating larvae under the skin. Sometimes you see it in the trunk, you see it in the feet, you see it in the hand, the arms, and this is indurated. So you actually feel the larvae, which is part of what you call animal hookworms, which invade man. So it is different from the currents or larva currents of strongyloides. Then we come to the severe form of strongyloides, which is when the immunity breaks down. And this is what we call severe complicated strongyloides. So the immunity will curtail and keep the number of larvae within the body. But once it's off, then the larvae multiplies rapidly. The auto-infection from inside and the auto-infection from the larvae making a U-turn in the body will be increased. And there will be lots of strongyloides larvae all over the body, and going into different areas, which, has not been the case when there is immunity. In the abdomen, they get severe abdominal pain, diarrhea, and sprue-like diarrhea. Sprue-like diarrhea is fatty diarrhea due to enteropathy, loss of proteins, edema, and this is can be very severe. Okay, losing protein, losing enteropathy. You can get fever, And sometimes you get necrotizing jejuvenitis, which lead to almost like a paralytic ileus, and the patient becomes very ill. Okay, the larvae in the lungs will cause something like Loeffler syndrome, but here it is severer, okay, like lung abscesses, respiratory failure, and even pleural effusion, and what we call hypereosinophilic pneumonia. And eosinophils are very important in the diagnosis of worms, you know. Here it is because the eosinophils is an immune cell which is seen in many of these worms. But here we get the hypereosinophilic pneumonia, abscesses, and the patient becomes extremely ill with strongyloides infection. But even the neurological, the worm or the larvae can go to the brain, you know, can go giving you headache, convulsions, and meningitis of the E. coli meningitis. Most of these intestinal worms, when they invite bacteria, it is often than not, it's an E. coli. And here they get a very funny sort of meningitis due to E. coli. Okay, so it's patient can be very very ill. Okay, so immunity is important. So it's the infection can spread out of hand. Okay, but you should remember that this is a tough worm, a very tough worm, because it doesn't only depend on the external life cycle, because here we have to treat the internal life cycle. Because if I clean the area from any reinfection, there is the auto-infection within the body which keeps the worm alive. This is what is important. The diagnosis, as I have said earlier, it's larvae. Rarely you can find the worm itself outside in the feces, but the larvae can be obtained from the stools. Otherwise, we can do jejunal biopsy, jejunal aspirate, which will give you the larvae as seen under microscope. The ELISA technique is the IgG detection. IgG detection against the infective larvae. So if you get the antigen from the larvae and do the ELISA technique, and then we can detect the IgG of the worm. PCR is, you know, is a more advanced and more better way, more refined and a more accurate way of diagnosing. So it's that difficult on diagnosis. The management or the care which we will give is giving the population a very good care, you know, especially sanitation. If you take off the feces from human touch, then that will be good. That is one major importance in management and control of the worm as a public health problem. Secondly, the health education is extremely important. And you could recall that we are almost repeating the same scenarios of control and management through all the different intestinal worms or Geohelminths. When we come to treatment, treatment is ivermectin. You remember with all the other worms, we started with albendazole. But here we are on ivermectin. Ivermectin is the treatment of choice. It is given ivermectin, which is originally the drug for onchocerciasis. Here it can be given in 200 microgram per kilogram body weight for 3 days. It is important. However, albendazole can also be used as an alternative for 7 days, 400 milligrams per day for 7 days. The patient has to be observed for cure, because if the immunity is good, these drugs will work marvelously. if the immunity is broken, these drugs need to be repeated as often as possible, maybe every 6 months or so, to clear the infection. So that is strongyloides. To remember out of this small lecture on strongyloides, this is a very important worm. It's now worldwide because of HIV and immune suppression. It has two sexual cycles, one in the external, one the internal. And if the external is not favorable, the worm can maintain its cycle within the body with auto-infection of two types. The infection within the intestine, the larvae goes back, attacking the mucosa and do the circulation of its mother, or it can go outside and U-turn from the anus and getting auto-infection. So the auto-infection is facilitated by the lack of immunity. There is what we are concerned with in patients with broken immunity like HIV is the complicated disseminated strongyloides, which can be fatal if not treated. So the follow-up of patients is extremely important after this. So that is what will finish with Strongyloides Strongyloides Stercoralis, and it is only the human. Human is known very rarely in other animals like dogs, but human is the main host of these strongyloides. Okay, the second half of this lecture is Arwa is with us now. We can share the slides. Hello. Okay, the second half is cystodes or cystode infection. Cystode infection. And if you can see the slide, the first slide, yes. Arwa went to sleep. Okay, cystode infections, as you can see there, okay, this is, okay, going back. Okay, cystode infection, these are actually also intestinal infections, but they are not nematodes, they are cystodes. And these are one of the oldest infections of human beings. Okay, the first one is very common in Sudan is Tina saginata, which we call beef tapeworm. Okay, and it is being contracted by eating raw beef or raw meat of the cow. And then we have the pig tapeworm, which is Tinea solium. And then we have the dwarf tapeworm, which is Hymenolopis nana, Hymenolopis nana. And then we have the fish worm, the fish tapeworm, which is Diphyllobothrium latum. I'm putting it in the slides because these names are not very easy, to remember. But these are the spelling of these worms: Tinea saginata, which is tapeworm, Duda asharitiya. And many people will complain of passing Duda asharitiya. They know it. Everybody knows when you have a segment of the worm getting out, then you can see it even wriggling, Tinea solium is not about the adult worm. It is about the larval worm, which is called cysticerci. Cysticerci or cysticercosis is the disease. The Hymenolopus nana is a minor infection. Diphyllobothrium latum is a fish worm, tapeworm, which only is found limited to certain areas. And if you are to remember anything about Diphyllobothrium latum, that it causes B12 deficiency, which gives you macrocytic anemia. This is the second worm which will give anemia. Remember, Ankylostoma duodenale gives iron deficiency anemia, depletion of iron because of blood loss and blood bleeding, ulcers in the intestine. Diphyllobothrium latum will be the other worm which can cause the infection causing B12 deficiency. Okay, we'll talk about the pig tapeworm. Why do I start with the pig tapeworm? Because now we are in Africa. Also in Sudan, we don't eat pork, but here, pork from different types of pigs are very common and eaten in different areas. This is why the larval infection of cysticercosis is common. But more so, it is in South America and Latin America. So cysticercosis is a very nasty disease, which can cause a lot of disabilities. In certain records, 1/3 of patients with epilepsy in South America are due to presence of cysticercosis in the brain. It is as that important. It's another cause of focal seizures in sub-Indian continent, in Indian continent. Then it is a common cause of epilepsy. So cysticercosis is a very, very important from point of view systemic. Up to maybe 10, 15 years back, we didn't have any treatment apart from the surgical treatment of this worm. Okay, it's common to all tinea or tapeworms. Next slide, Arwa. So it's the common picture of tapeworms. This is a flat. This is a flat worm, okay, which can be very long. The bottom of the picture, you can see the worm, which is a tapeworm, and then they can reach up to meters, meters of length. And the head, it has a head. This is the head, okay. If you concentrate, then they have scoliosis and hooks, which they can attach themselves to the intestine. Very important is after the head, you get the neck. And the neck is the place of production of new proglottids. Proglottids, the segments, it's called proglottids. Proglottids, which is spelled Proglottids, proglottids. So progressively, more mature segments will spring from the neck. Okay, so the most mature segment is at the end. And once it is mature, it gets detached from the worm and goes through the intestine outside. And patients will see it. It's very clear that this is a tapeworm, which can be seen, and it's wriggling. The segment or the proglottids is a hermaphrodite worm. It's a complete worm, which contains males and females and eggs. Okay, so the proglottids goes out in the stools, may be then eaten by the beef, or here in our case is the pig. Pigs scavenging on dirt or in dead bodies, feces. Then they can eat the segment or proglottids, and then they contain the eggs, and this goes into the body and form the adult worm. Okay, so that is the worm. If you are to treat the worm, you have to get the head out. If you don't get the head out, you have not treated the worm, because if you cut the worm at any level below the neck, then a new worm can develop into a very long worm. So in days gone by, we used to give treatment like niclosamide, which is a good drug for tapeworm, then and we give an enema. We give an enema or purgative, better purgative, to clean the intestine, and we collect the stools to see if the head is there. If the head is there, the patient is being treated. If the head is not recovered, then it is still in the body and it can produce a lot of other probabilities or segments. So next slide. Okay, this is if it is apparent. This is tinea solium. As I said, I will concentrate on tinea solium. So tinea solium, man can be contain the adult worm, and unfortunately, it can contain the larva. The side diagram here is the larval stage, and all complications, morbidity, are due not to the one on the right, the adult worm in the intestine, but the one on the left, which is the ova or the larvae. Okay? The adult worm will get out of the human feces or in the human feces, and these will be either segments like this or eggs, or these are eggs. Okay? Embryonated eggs or gravid proglottids pass in feces. Okay, this is what it is, and then this will infest the pig. Okay, and the pig produce then the adult worm or the ova, or what we call the here as it is here is oncospheres. Oncospheres. The oncospheres are embryonated eggs. Oncospheres are impregnated eggs. If the eggs hatch, it will give an oncosphere. So the oncosphere is taken up by the pig, okay, and then it develops into a full larva or cysticercus, which then rest in the meat of the pig. And when people start eating the raw meat of the pig, they actually ingest the oncospheres from the stomach. And here goes on the left side that the embryonated worm will go into the body as an intermediate host. And from there, it can get distributed all over the body. So the oncospheres will turn into cysticerci, cysti, not cystocerci. It is cysticerci, cysticerci, cysticerci. And the most important places where they go to is the brain. So it is totally a disease which is neurological and in the eye. So it is something which we really need to think about. Epilepsy. And the first time, when this was discovered, is discovered when people had epilepsy in certain areas, and it was discovered that it is due to cysticerca. In the eye, you can get retinal problems, okay? But in the brain, you can get cysticerca in the ventricles. It can be in the subarachnoid spaces, okay? And it can be intrapyramidal, intraparenchymal, or extraparenchymal, okay? And gives all range, apart from epilepsy, any type of epilepsy, be focal or be grand mal epilepsy, depending on where the cysticerci will be deposited. So it's, and you can get cognitive impairment, cognitive function, which is understanding, and then you can get psychiatric symptoms. One important thing is also you get meningitis, which is chronic meningitis, what we call chronic meningitis. And chronic meningitis is about headache, severe headache, but no neck stiffness, and there is a continuous lack of attention. So the patient is like somebody holding his attention from you. So this is meningitis, and this is usually invited by the cysticercus, other types of infection, like the E. coli infection. Okay, so cysticercosis is one of the major problems in Latin America and in South America, and it is one of the causes. It's very difficult to, you can easily diagnose it, and the great progress of diagnosing has been in the new technology or new imaging, the particularly CT scan and particularly MRI. Okay, the MRI will disclose an area of a cysticercus, and from the name, it is a rounded appearance with fluid inside and pressure. And these are what is available, what is seen in the MRI. The MRI has also given us an opportunity to study the natural history of this cysticercosis, because then we can follow up these patients with MRI to see if they do generate or they can progress. And very clearly, you can see if it is adding more babies inside the cyst. CT is also very helpful, and these are now the modalities of investigation. Unfortunately, in many of the areas where cysticercosis is, the MRI is not, CT are not available. So it's cysticercosis is the larval infection of Taenia solium. So it's the pig harbors the larva, the adult harbors the adult worm, but unfortunately, the human being also harbors the larval stage. And the whole disease comes from the larval stage, not from the adult worm in the intestine. Okay, as far as treatment is concerned, this is again very controversial. Okay, very controversial. I have been in a committee, a WHO committee, to try and devise a treatment schedule or guidelines of how to diagnose and how to treat. And the dialogue was, there are no many papers on the treatment of cysticercosis. Okay, as far as the worm itself, the adult worm in the intestine, we have drugs. Okay, we have drugs like praziquantel. Praziquantel is a drug of schistosomiasis, but in a smaller dose is very effective in tapeworms. So if you have Taenia saginata, your drug of choice will be praziquantel, the 40 milligrams per kilogram body weight, like in schistosomiasis. It is 15 milligrams per kilogram body weight in Taenia saginata. And that also goes for Taenia solium as an adult worm. But we are talking here about cysticercosis. And cysticercosis, by definition, it is the larval infection of Taenia solium. So it's that important that we will concentrate on this. Okay, the drugs which have been advocated for the treatment are praziquantel again and albendazole. Maybe albendazole first and then praziquantel. These are two drugs which has to be given for a longer period, and repeated. Okay, you can follow by CT scan or by the MRI. In the MRI, you can see that there is a reduction on the cysts and then weakening of the whole structure, and you can see calcification. By the time when you see calcification, then the active larva in the cyst is now getting dead and allowing itself to be calcified. So it's the follow-up will be by the MRI and CT scan. So it's the disease which is rather sophisticated, unlike the simple ones like Ascaris, where you can get the eggs and get the treatment. This is more of a specialized neurological disease of epilepsy, focal or grand mal, and then the eyes can be affected, especially the retina, giving impairment of vision. Okay, this is what is important, and I stress that I started with solium not because it's very common in Sudan, and the disease is not seen in North Africa, where there is Muslims who do not eat pork, or in areas where it's dominant by Muslims who do not eat pork. So it is a disease of pork meat. And luckily in Europe, it has been, almost eliminated, because we don't see pigs in Europe with that larvae in their muscles or in the meat. And this is the two ways. The way is elimination of the worm from human intestine, and definitely the sanitation there has been improved, so nobody will void empty his bowel in the open. Secondly, there is very stringent regulations about cleanliness of animals, and check when they are slaughtered for the meat. The meat will be very inspected, carefully inspected. And if you just by eye seeing, you can inspect the meat and you can find some of the ovaries and some of the cysts in the meat, then that meat will not be will not be suitable for human consumption. So with that, you have to treat both human and to treat the pig from the worm, from the larval worm. So its treatment is obviously hygiene, public education, and drugs. Drugs are mainly albendazole and praziquantel. Rarely we can revert to surgery. If we really find a space-occupying lesion in the brain by CT and MRI, neurosurgeons can get in and try to empty or remove the cyst. Okay, this is obviously requiring a lot of hospital support, because this is brain surgery, which is not taken lightly in many of the secondary service hospitals in the third world or in tropical. So I think Taenia saginata is the other beef tapeworm, very similar, but it doesn't have the man is the only adult, is the only host, okay, and harbors the Taenia saginata, the big one, okay. If we lost the slide, but anyway, the Taenia can stay in the body for a very long time. It's often said that it eats or it consumes the host food, but this is not very true. Many of these Taenia saginata can live there, and patients can live happily. It all depends on what type of food and how much food you can take. But it is being said that it causes abdominal pain and loss of nutrients from the body. Okay, but the diagnosis is very easy. You can see the proglottis, or you can cover the ova. They can cover the ova, and The commonest presentation may be that the patient, when he looks at the feces, he will see a wriggling segment or proglotis. So this is one of the area of diagnosing. And as I said with ascaris, it's not very nice to have living bodies coming out of your body, either by vomiting, like in ascaris, or by passing ascaris through the anus, or passing teres aginata segments through the anus in the feces. So if you see that, you can feel like you are rotting inside. And that is very important. Simply, if you warm up the meat or you cook it well, like what we do, like what we do in Sudan, or give it, even in oil for a while, then the larvae will die and will not be effective. If you go to especially in Africa, if you go to a restaurant and if you request beef, then it is advisable that it will be well done, and that will kill most of the larvae, if any, in the meat. But if you are careful, then you will not get that teres aginata. Okay, teres aginata again treatment is praziquantel, 15 milligrams per kilogram body weight. Just to remind that unless you see the head out, then the patient is not being cured, because the neck will produce more proglotis. Even if you cut all the proglotis up to the neck and you leave the head and the neck, then the worm will regrow into the same size you have started with. So it is important to look into the feces to see that you have got the head out. So I think with that, that is finishes our time. I don't know if there are any questions been thrown from here or there. I'm very pleased that 3 of the students, in 3 or 4 from the students in batch 26, are their thesis is on intestinal helminthiasis in Rwanda, in rural areas of Rwanda. So it is important that if we are living in a country like this, we care about the diseases which is being common and prevalent. I would just like to announce that the University of Medical Science and Technology has gone into an MOU with a research center called CKIN, okay, with Professor Janine, who is a known researcher in these areas, who are getting a lot of funds from outside. And UMST is running a course or a week of training in research methodology. It's going to be on the 15th of this month in Kigali, fully sponsored by UMC, and we're getting speakers from America. Charles McKenzie, if some people will know him, is a friend of UMC. Professor Noma, also coming, but 2 from social scientists from Sierra Leone are coming, and Dr. Atif Fazari, who is a clinical obstetrician but interested in research, clinical research, will also be there. And Dr. Arwa, who has a master's degree in public health, and hopefully myself will be there to train some of the associates of research in Kigali. With that, I would like to thank you very much for being with me, and thanks for your attention, and thanks for Arwa for arranging the presentation, particularly the slides. See you next Sunday. Thank you.